Assalamualaikum warahmatullahi wabarakatuh. My name is Dr. Muhammad Khairul Hanan bin Muhammadiyah. I am a medical doctor currently pursuing my Master of Public Health in University Science Malaysia. Today, I will share about important topic, the complicated safety issue that come out when breastfeeding while having HIV. This subject goes beyond the scope of clinical medicine. It's very complicated topic. On the other hand, breastfeeding is clearly good for babies because it gives them important nutrients and immunity. On the other hand, there are fears and risks of HIV spread. Mothers with HIV are in very tough spot because they want to breastfeed and give the child the best start in life. But also, they are worried about their own health and the risk of passing the virus. The other option is formula milk, which is safer for HIV spread, but comes with its own issue, especially in places with few resources where the risk of waterborne disease is high. Today, we will talk about this aspect, breaking down the risks and benefit of breastfeeding in this presence of HIV, as well as the personal struggle women face when making this decision. Let's go into this conversation with open minds and heart, hoping to give those who are affected information and support. Let's go. Breastfeeding in HIV, is it safe? This is my presentation outline. According to Malaysian National Breastfeeding Policy, it is recommended that every mother exclusively breastfeed her baby from birth until 6 months of age and continues breastfeeding up to the child's second year. Additionally, the introduction of complementary food is advised starting at 6 months. This guideline aligns with the global recommendation set forth by WHO and UNICEF, emphasizing the importance of breastfeeding for optimal infant health and development. Breastfeeding is a natural and beneficial way to provide infants with the nutrients they need for health and growth. This process brings with it a multitude advantage for both baby and the mother. Here are some of the key benefits. Breast milk provides the ideal nutrition for infant. It has nearly perfect mix of vitamin, protein, and fat, everything your baby needs to grow. Breastfeeding increases baby immunity, offering more resistance to viruses and bacteria, which means less chance of getting infection. Breast milk contains everything the baby needs to keep their digestive system healthy and is easier to digest than infant formula. The act of breastfeeding promotes brain's development in children, which can have long-term benefits for cognitive development. It reduces the risk of sudden infant death syndrome, SIDS, providing a protective effect during a critical period of an infant life. It promotes healthy weight gains and helps prevent obesity in infants by adapting over time to meet the child's changing nutritional needs. Breastfeeding also fosters physical and emotional bonding between the baby and the mother, which is beneficial for the emotional well-being of both. For mother, breastfeeding is linked with a reduction in the risk of breast and ovarian cancer, possibly due to hormonal changes during lactation. It is important to note that breastfeeding also offers economic benefit as it don't cost money. According to Malaysian guideline for strengthening program of HIV and syphilis infection from mother to child, there is a significant risk of vertical transmission from mother to child of HIV when a mother breastfeeds her child, even she is receiving antiretroviral therapy. The transmission risk is noted to be between 14 to 16% because of the high risk of transmission through breastfeeding. This guideline recommends the use of formula milk for infant born to HIV positive mothers. It emphasizes the importance of ensuring that this practice is implemented effectively. Furthermore, it is imperative to provide education and readiness to mother regarding appropriate hygiene practice. This is to make sure that formula milk is prepared and consumed safely from prevent HIV transmission. While the use of formula milk is recommended to prevent HIV transmission from mother to child, there are mothers who may still choose to breastfeed. For this mother, the Malaysian guidelines stipulate strict conditions to minimize the risk of transmission. Mothers who intend to breastfeed first need to consult with a pediatrician. The mother must be free of any breast injury or infection such as cracked nipple, ulcer, or mastitis to reduce the risk of transmitting HIV through breastfeeding. The mother's viral load should be consistently below 50 copies to decrease the risk of transmission. The infant's HIV status should be monitored with a PCR test every month until the virus is no longer detectable in the baby's blood. Mixed feeding, which combine breast milk with other foods or liquid, is not recommended due to a higher risk of HIV transmission. Exclusive breastfeeding is advised. Both mother and child should adhere to antiretroviral treatment regimen and attend all follow-up visits. Mothers should seek early consultation for care before pregnancy to ensure that both mother and child receive the best possible care from the start. By adhering to this guideline, the risk of HIV transmission through breastfeeding can be significantly reduced by ensuring the health and safety of the infant. The British HIV Association provides clear guidance for parents with HIV on how to safely feed their babies, emphasizing that formula milk is the safest option due to zero risk of HIV transmission post-birth. However, for those considering breastfeeding, strict adherence to the following criteria is essential. The parent must maintain undetectable viral load by consistently taking anti-HIV medication as prescribed. Exclusive breastfeeding is recommended for the first 6 months if chosen. Formula milk can be used to supplement breastfeeding, especially during the initial phase of establishing breastfeeding. No solids or other food should be introduced to the baby before they reach 6 months of age to avoid increasing the risk of HIV transmission. The risk of HIV transmission through breastfeeding can be increased under certain health conditions. These include the presence of a detectable viral load in the parent, breast conditions such as mastitis or cracked nipple, and if either the parent or baby experience diarrhea or vomiting. During such event, it is advised to abstain from breastfeeding and seek advice from an HIV clinic team. It is important for parents with HIV to have a regular follow-up with healthcare professional to ensure the health and safety of both parent and the baby throughout breastfeeding period. The National Institute of Health, United States, emphasized the importance of evidence-based, patient-centered counseling to guide individuals with HIV in making informed decisions about infant feeding. Key points from the National Institute of Health recommendation includes discussion about infant feeding option should begin before conception or as early in pregnancy as possible, with ongoing reviews throughout the pregnancy after delivery. Individuals should be made aware of the following: using properly prepared formula or pasteurized donor human milk from a bank completely eliminate the risk of postnatal HIV transmission to the infant. Maintaining an undetectable viral load through consistent antiretroviral therapy (ART) throughout pregnancy and the postpartum period can significantly reduce the risk of transmitting HIV via breastfeeding. While the risk can be reduced to less than 1%, it is not completely eliminated. For HIV positive individuals not on antiretroviral therapy or who do not have a suppressed viral load, especially during the third trimester and at delivery, NIH recommend replacement feeding. This includes the use of formula or bank pasteurized donor human milk to eliminate the risk of HIV transmission through breastfeeding. For those on ART with a sustained undetectable viral load who opt to breastfeed, NIH advocates for support in their decision, acknowledging the reduced risk of transmission due to effective viral suppression. HIV positive individuals who choose formula feeding should also receive full support. Healthcare providers are encouraged to discuss any potential barriers to formula feeding and work to address this issue, ensuring that the parents have the resource they need for this option. NIH clearly states that engaging Child Protective Service or similar agency is not an option. NIH clearly states that engaging Child Protective Service or similar agency is not an appropriate reaction to the infant feeding choice of HIV positive individuals. This shown the importance of respecting the rights and autonomy of parents living with HIV in making decisions for their children's nutrition. In providing this recommendation, NIH emphasized the importance of individual choice and the need for supportive healthcare service that respect the decision of HIV positive parents while prioritizing the health and safety of the both infant and the parents. In 2016, WHO guideline on HIV and infant feeding marked an evolution in the approach to breastfeeding for mothers living with HIV. The new guideline recommend that mothers living with HIV breastfeed for at least 12 months and may continue up to 24 months or longer while receiving support for strict adherence to antiretroviral therapy. This is an update from the previous guideline, which suggested exclusive breastfeeding for the first 6 months, followed by an assessment to decide whether to stop or continue based on the mother's ability to provide a nutritionally adequate and safe diet without breast milk. In environments where health service offer lifelong ART and counseling to promote adherence, there should be no restriction on the duration of breastfeeding for women living with HIV. This facilitates continued breastfeeding as an viable option. This guideline reassures that ART substantially lowers the risk of postnatal HIV transmission. While mixed feeding is less recommended, exclusive breastfeeding is advocated when it's the sole nutritional source for the infant. It is highlighted that shorter breastfeeding periods, even than 12 months, are preferable to not breastfeeding at all, provided that ART adherence is maintained. WHO updated guidelines reflect a comprehensive approach that supports breastfeeding while managing HIV transmission risk, with the overarching goal of promoting the health of both mother and the child and infant feeding. But where there are differences in recommendation, infant feeding recommendation differ significantly across various parts of the world, especially for mothers living with HIV. These differences are primarily due to varying health risks and resources available in different settings. Recommendation in high and middle income countries in like UK, Europe, and US, the prevailing recommendation is that formula milk is safer than breastfeeding if the mother has HIV. This is because the countries have the resources to support the safe preparation and use of formula milk, reducing the risk of HIV transmission to the baby. The World Health Organization recognize that in areas where children are at high risk of diarrhea, pneumonia, and malnutrition, condition often this condition, which is often found in lower income countries, the situation is different. Here, the protective benefits of breastfeeding outweigh the risk of not breastfeeding. Even considering the mother's HIV status, it is crucial to balance the risk of HIV transmission through breastfeeding with the risk of other serious illness that can be prevented by the antibodies and nutrients provided by breast milk. In many low-income countries, approximately 1 in 20 babies die before their first birthday, often due to conditions like diarrhea, pneumonia, and malnutrition. Breastfeeding can provide protection against this condition. While formula milk can be nutritious breast milk substitute, it has notable disadvantages in some regions. These include the lack of protective antibodies against common disease, the requirement for clean water and facilities to prepare it safely, and the cost, which can be prohibitively expensive for some families. The recommendations are not one size fits all and must be adapted to the context of local health risks, availability of healthcare resources. There are various issues that can arise with the use of formula milk, especially in low-income settings. Formula milk preparation require clean water and sterilized equipment. In areas where they are not readily available, there is a heightened risk of bacteria that can lead to diarrhea and vomiting, which are dangerous for the infant. Unlike breast milk, formula milk cannot enhance a baby's immune system in the same way. Breast milk contains antibodies and other immune-boosting properties. In low-income countries, the benefits of breastfeeding are even more pronounced, as it can significantly reduce infant mortality by protecting against lethal infection like pneumonia. The cost of formula milk and the necessary sterilization equipment, such as bottles and cleaning supplies, can be a substantial financial burden. This is particularly challenging for women in low-income countries where the expense of formula feeding can be prohibitive, impacting their ability to provide adequate nutrition to their infant. It is important considering this issue when discussing infant feeding options, particularly in resource-limited settings and the need for support system to help. Does U equal to U, undetectable equal to untransmittable apply to breastfeeding? Breast milk is unique compared to other bodily fluids. It's important to recognize that having an undetectable viral load reduces but does not eliminate the possibility of HIV transmission to the infant through breastfeeding. The presence of immune cell in breast milk, which can harbor HIV, make it potential source of transmission. These cells are not always detected by standard viral loads tests, and given the volume of breast milk a baby consumes, about 1 liter per day, the risk, while low, it remains. Antiretroviral therapy (ART) significantly decrease the amount of HIV in breast milk, yet it may not eliminate it entirely. The efficacy of ART in reducing the viral load is a monumental step in decreasing the risk of HIV transmission, but does not guarantee its non-transmittable through breast milk. There have been instances, although few, where babies have contracted HIV from mothers with undetectable viral load. This case highlight the need for continued vigilance and support for HIV positive mother in making informed decisions about breastfeeding. This is to conclude that you equal to you is a powerful message in the fight of against HIV transmission. The application of this principle to breastfeeding is not absolute, and the decision to breastfeed must be made be careful. The PROMISE study is an international research effort conducted across 14 facilities in 7 countries. Its goal to explore the outcome of extended infant ARV prophylaxis coupled with maternal ART during breastfeeding up to second year of the infant's life. The key finding presented in table 2 as follows. The study compared the probability of HIV infection or HIV death between the two groups, those receiving maternal ART and those receiving infant nevirapine prophylaxis. This table show that probability of getting HIV infection at the 6-month age is 0.3, and then at 9 months is 0.6, and then at 12 months 0.7, and 18 months 0.7, and at 24 months is 0.7. So this finding has significant implication for HIV management in breastfeeding population. This study provides data to guide healthcare providers and policymakers in crafting strategies to ensure that health and survival of infant born to HIV positive mother, particularly in regions where breastfeeding is culturally and nutritionally vital. For the conclusion, breastfeeding guidelines for people living with HIV differ across countries. These variations are primarily due to difference in healthcare infrastructure and the risk of infectious disease. High-income countries where the risk of diarrhea, pneumonia, and malnutrition are lower, formula milk is generally the recommended option for people living with HIV. The preference for formula milk is due to the availability of clean water and advanced healthcare system, which can safely support formula feeding and mitigate the potential risk. In low-income countries, conversely, where infants face greater risk from infection and malnutrition, breastfeeding is advocated despite the mother's HIV status. Breast milk, essential nutrients, and immune protection are crucial, especially in environments where clean water is scarce and the risk of disease is high. Principle of U equal to U, undetectable equal to untransmittable, does not fully apply to breastfeeding, while the risk of HIV transmission from mother to infant is significantly reduced when the viral load is undetectable. It cannot be considered completely eliminated. In light of this consideration, it becomes clear that the approach to infant feeding among positive HIV must be tailored to the specific circumstances and the need of each region. Healthcare providers and policymakers must weigh the benefits of breastfeeding against the potential risk of HIV transmission, taking into account the availability of resources and the prevailing health challenge. Ultimately, the goal is to ensure the well-being of both mother and child, providing them with the best possible start in life while minimizing the risk of HIV transmission. This balanced perspective is crucial in formulating guidelines that are both scientifically sound and empathically applied, respecting the diverse context in which individuals with HIV live and raise their children. With that, I conclude my presentation. This is the reference for my presentation. And then thank you very much for your attention.